Alaikum warahmatullahi wabarakatuh. Today we will have a case report published by Ricucci et al. In 2025 titled Extraosseous Inflammatory Lesion of Endodontic Origin in a Mandibular Premolar with Failing Root Canal Treatment. Apical periodontitis usually stays within the cortical bone, but sometimes the infection perforates the cortical plate and extend into soft tissue. That's called an extraosseous inflammatory lesion of endodontic origin. It's a rare situation, and this report is the first histologically confirmed this case. This case was a 77 years old woman had recurrent abscess and swelling in the lower left premolar region for almost a year. Patient reported the episodes had been treated with antibiotics, but they kept coming back. Clinically, a sinus tract was draining pus near the first molar, and the first premolar showed severe occlusal wear, exposed dentin and enamel cracks, but no caries. The tooth was non-vital and tender to percussion. A periapical X-ray showed a 6 by 5 mm radiolucency around the apex, and this tooth was diagnosed as a necrotic pulp with a chronic apical abscess. Treatment for non-surgical was done under a microscope using ProTaper system with 5.25% sodium hypochlorite and 70% EDTA, both ultrasonically activated, and the case was medicated using calcium hydroxide. After 3 visits, the sinus tract kept draining pus with mild discomfort. The canal was obturated using PCC on a single cone Gataperca, and the post-operative radiograph showed a separated size 10K file fragment beyond the apex. 4 months later, the sinus tract persisted. A Gataperca tracing confirmed its path to the periapical lesion, indicating that the infection did not respond to non-surgical treatment, so a surgical intervention was required. For the surgical phase, during flap elevation, a 15 mm strand of granulation tissue was found extending from the sinus tract exit to the apex of the mandibular first premolar. This tissue originated from an opening in the cortical plate near the root apex and could be easily separated from the periosteum with a blunt dissection. Once detached, a shallow depression on the cortical bone surface became visible, confirming the path of the inflammatory tract extending from inside the bone to the extraosseous soft tissue. Apicoectomy was done, removing the apex and pathological tissue. A retropreparation was sealed with MTA. No graft or membrane were used, and the sinus healed within a week, but the patient experienced numbness in the left side of the lower lip and the corner of the mouth. A follow-up radiograph after 1 year showed that the lesion had healed completely, with a new bone filling the cavity. Numbness had subsided, and the tooth was asymptomatic. For the histological finding, the specimen was processed for HND and modified Brown-Bren stains. Sections revealed clean canal wall, coronally but heavily bacterial biofilm in the apical ramifications, including around the separated file fragment. Biofilm extend onto the resolved apical surface and into the periapical tissue with necrotic debris. Surrounding tissue showed acute neutrophils infiltration and chronic inflammatory cell within the fibrous capsule. The extraosseous portion had dense collagen externally and central sinus-like channel filled with necrotic debris and red blood cells without epithelium, this providing a chronic inflammatory tract extending beyond bone. So in this case report, authors conclude that extraosseous inflammatory lesion of endodontic origin can be regarded as a different manifestation of apical periodontitis, and further studies evaluating its prevalence and the clinical implications should be encouraged. Thank you.